Good evening and welcome to this presentation. Welcome to the purpose. Stories welcome colorful, vivid detail. This approach helps grab the attention of the audience. Taking personal experiences and reflecting on a situation is helpful in avoiding the mistakes of the past. This presentation will show us how to reflect on uncomfortable situations and revive the scenario into a positive preparation for future use. In order to fully correct a misunderstanding, we must first know the mission and goals that we are representing. Our unit strives to put the patient safety first, ensure a positive and safe work environment for our coworkers, and create a team of healthcare workers that work as one unit. One morning during daily rounds, I was presenting a patient to a locum intensivist. The patient had experienced a cardiac arrest while at home and was resuscitated prior to arriving at the hospital. It is the hospital policy that the patient receives a 24-hour cooling therapy following the event of cardiac arrest. This particular patient had been placed on cooling therapy and was given propofol and fentanyl for vent compliance. Our unit protocol calls for the proper sedation and pain control during cooling procedures to ensure the patient is not under any undue duress. I presented the patient to the intensivist. He asked why the patient was not on sedation when he was not responsive at the time. I explained that per standard procedure, the nighttime intensivist placed the order for cooling, sedation, and pain management. Perplexed, the intensivist shrugged off the conversation and asked me to turn off the patient's sedation and pain medication. He then talked to the family and performed a neuro exam on the patient. The physician placed orders on the patient and told me to continue the 24-hour cooling procedure. When the physician left, I turned the propofol and fentanyl drips back on at the previously established rates and continued on with the day. Later that day, I called the same intensivist to tell him about a change in the patient's cardiac rhythm. The physician came to check on the patient and pulled me to the side. He sternly asked why the patient was back on the propofol drip. I told him that I continued the cooling procedure per his verbal order, and the standard procedure was to sedate the patient. The intensivist stated there was no reason for this and demanded the drip be turned off. I complied while letting him know that there was never an order to discontinue the drip. I also told him that he was unclear when he initially rounded on this patient. It was my understanding that he wanted the sedation to be off to perform his neuro exam. Since the order was never discontinued, I followed the procedure and continued the propofol drip. The intensivist then said, "Here's your official order. Turn off the propofol and leave it off. There is no need for it, and you should know that. Use your common sense." I was very frustrated at this point, and I explained that I only followed standard protocol. I also explained that his prior encounter was distracted and unclear. The intensivist agreed that this was true, but he stated I should have gotten clarification if the plan of care was not clear. In simple terms, organizations are a conglomeration of individual conversations. The individual conversations within an organization show how each member sees his or her organization, culture, and mission. Common ideals or misconceptions can influence the perception of this organization as a whole. This is evidenced in our hospital throughout the nursing staff. Many nurses talk about our hospital and how it is not the same since the buyout. This perception has led to the ideal that the hospital is fueled by profits rather than the benefits of our community. Patterns of relating specifically look at the way staffing interacts. Our hospital is stuck in an impersonal spiral of disconnect. I cannot remember the last face-to-face meeting that was given by our corporate staff. Email bulletins and inter-office memos have taken the place of familiar faces. This sets the tone for expendability. Our staffing is left feeling powerless and inferior to the names on a business card. Patterns of meaning are meant to reflect the goals and themes of our hospital. Conversations with nurses on our unit mock the true goals of the hospital. The majority of the staff feels that the profits outweigh the need for excellence in patient care and safety. Many nurses feel underpaid, overworked, and expendable. These types of conversations are what upper management needs to focus on. Our hospital's true mission cannot be met if there is a disconnect in its true intention. Our hospital needs to focus on the choices and preparations of its perceptions of the current staff. These integrated ideals are shaped from the lessons of our past. Face-to-face conversations can take moments of a CEO's time, but the impact on the staff is monumental. Having a visit from a leader whose time is rarely shared makes staff feel noticed. Talking and listening amongst the board and the staff allows for common goals, ideals, and perceptions to be pursued by the hospital. To have this complete sense of being, we must be in bringing the entire organization to the same page of realization. Town hall meetings give staff the opportunity to voice their concerns and concepts while sharing valuable insight to upper management. These personal opportunities allow for tiers of the company to meet on the same level. Communication is much more than words. Nonverbal cues such as facial expressions and body movements can speak loud as words that are being spoken. Memos and emails do not shed light on the true tone of conversation. Our hospital needs to be mindful that the staff is valuable. Nursing conversations suggest the opposite. Nurses feel like they are being pushed out for new recruits with less experience and a lower salary. Innovation needs versatility. I have a small addition, but we are an unstoppable force. This idea allows for forward progression and a healthcare field with endless possibilities. Nurses in our company speak of ideas for new products, protocols, and ways to save time and money while putting patients first. These are examples in one field of staffing. I am sure that within the facilities, doctors, techs, and other specialties have ideas to bring forward. Together we can make progress happen. This story could have been handled more effectively. When the intensivist asked me to turn off the propofol drip, I could have asked for clarification. A simple, respectful question could have changed the tone of conversation. Feelings of inferiority stopped this from happening. The intensivist gave a vague request and turned his back to me to talk to the patient's family. I did not feel that I had the right to question him at this point. This pattern of relating shows how a physician who disregarded the nurse through verbal and nonverbal cues and a nurse that feels inferior by not speaking up. This situation could have gone better if the physician and I had used the both and idea of conversation. We could have come together after rounds and recapped a clear center plan of action. Our hospital received a patient that was status post-cardiac arrest. The evening shift initiated our unit protocol by receiving orders from the night intensivist for a cooling and sedation and pain management. I received the patient during morning handoff report. We had a guest intensivist who was new to our unit. I introduced myself and gave him a bedside report of the patient's condition and treatment. The intensivist voiced a concern about the need for propofol in a non-responsive patient. I explained to him that our standard procedure, and I asked how he would like to proceed with the patient's care. The intensivist stated that he would like to assess the patient and converse with the family. After the physician finished his bedside assessment and explanation of care with the family, we stepped outside the patient's room away from distraction. The intensivist asked that I discontinue the propofol drip for the time being. I understood his reasoning and I asked that he place the orders in the hospital system. I verified his orders were placed and discontinued the sedation drip as planned. This story was changed by simply removing assumptions and distractions while following the proper protocol for order changes. Communication, including verbal and nonverbal cues, were used to enhance the patterns of relating and meaning within the conversation, and the result was successful. This outcome displayed the culture of our unit's mission to place patient outcomes and safety first.